Okay, I am very pleased to introduce Dr. Carol Crawford. She, as mentioned, she is a clinical associate professor at the University of Washington School of Pharmacy. She's heavily involved in the teaching and development of the school's geriatric curriculum. So some of you attending have probably already heard from her. She works in both inpatient and outpatient geriatric settings at Harborview Medical Center, working collaboratively with providers and patients, providing clinical pharmacy services. She lectures at the School of Pharmacy as well as at the UW Division of Gerontology and Geriatric Medicine. She's been involved in our Project ECHO, and her professional interests are education, transitions of care, falls and medication safety. She has tremendous expertise that she's going to share with you today on opioids in the elderly. Welcome, Dr. Crawford.
Thank you. Thank you. So, so today we're going to discuss opioids in the elderly. And just to get some paperwork out of the way, no financial relationships or conflicts that will influence this lecture at all. And the topic of pain is actually a really huge topic. Just to center ourselves and kind of just wrapping ourselves around the kind of the thought and discussion for our lecture today, it's a very central topic to most patients. So some statistics here, approximately 100 million people actually have persistent pain in the US. And the cost of this of pain management, so this is including loss of productivity, inpatient, direct medical care, et cetera, is in the neighborhood of $600 billion a year. And that actually is larger, that cost to the United States is actually larger than the combination of management for cancer, diabetes, and cardiovascular disease combined. And as you probably know, those are very complicated, diagnostically driven disease states. So obviously this is very expensive kind of management for pain. And when we're looking actually at adverse drug events related to opioids, the reason why we're especially concerned in the inpatient setting, for instance, is because opioid patients that are actually admitted for an opioid-related adverse drug event have longer stays in the hospital by approximately 3 days. They have greater risk of a readmission, and there's an increased, significant increased cost in their admission, their total admission time. What speaks to me as a pharmacist as far as motivation is that when we look at those adverse drug events that are caused by analgesics, approximately 30% of those events could actually have been avoided. So it just tells us that we need to be diligent about our monitoring and prescribing of opioids in general. So this disease, or I shouldn't say disease, this topic actually is very important as far as management, and is very much a geriatric issue. So when we look specifically at geriatrics, we see that opioids are prescribed to geriatric patients approximately, when we're looking at the total amount of opioids that are prescribed, 30% of those are prescribed to our elderly. And when we think about pain and pain prevalence in our elderly population, 1 out of every 3 patients, elderly patients, have a chronic pain issue. And that doesn't change with age. So when we talk about geriatrics, we often talk about young geriatrics. So kind of the 65 to 80-ish age. And then those older than that, we call kind of our older geriatric patients. But the incidence of kind of chronic pain doesn't change. Obviously, we're concerned about this for our patients because besides quality of life being decreased if pain management isn't optimized for these patients, oftentimes it really prevents them from maintaining an independent lifestyle. So if patients can't, because of pain, can't get to the grocery store to do their kind of activities of daily life, then they actually have an issue. Obviously, unchecked pain is problematic from a mobility standpoint, and actually from a cognitive standpoint. And there's a higher level of disability just in general when pain is not managed. So today, before we talk specifically about opioids, I think it's important. And so what I'm proposing for our agenda today is that we actually just review pain management in general. And in that way, we can understand where opioids' place in therapy is for our elderly adult. And I'm going to talk also about providing you actually with some screening and monitoring guidelines to ensure that when we are prescribing opioids, we're doing that in the safest, most thoughtful way. And then we'll obviously, or I will be highlighting some issues unique to opioid management in the older adult. I will be using some specific cases along the way, and they are multiple choice since I'm not in front of you and we can't kind of freely converse. I won't be really monitoring the chat, so they're more kind of, I won't be expecting an answer necessarily from you, but it's just a way of kind of framing some of the things I want us to think about and in order to contemplate them. So just to start thinking about our patients and opioid prescribing, I've set up here 4 or 5 examples or scenarios of patients, and I'll just read them over briefly, just to get us in the thought process of when would we feel comfortable prescribing an opioid? And if we're not feeling comfortable, could we change the scenario so that we would feel more comfortable? If in fact an opioid is warranted or would be optimal for the patient. So 78-year-old patient, hospice care for terminal lung cancer. Probably pretty straightforward that an opioid would be indicated. 68-year-old, a history of depression, anxiety, chronic pain. How do you detox? Positive for cocaine, opioids, and prescribed benzodiazepines. So kind of two ends of the spectrum. This patient, we would not be considering that being a safe kind of prescribing habit. And then the next 3, so a 66-year-old hepatocellular carcinoma, recently enrolled in palliative care with the comorbidity of severe alcohol use disorder. Letter D, a 90-year-old with chronic back pain with neurocognitive disorder and a history of falls. And the last one, an 80-year-old with severe lumbar stenosis with a family caregiver with an opioid use disorder. So when we're thinking about, again, prescribing opioids, it is important, obviously, to get the whole picture of the patient. So what medications they're also on, what comorbidities they have, what history they have, and who, especially, this is significant for the elderly population, who is their caregiver, and are they able to, help monitor, et cetera, to keep the patient safe while they're on opioids. Cognitive impairment is obviously prevalent in the elderly population, and that is also something that we need to keep in mind when we're prescribing opioids for patients, especially if they have cognitive impairment and they're independently living. So as was mentioned kind of in the introduction, our clinic here at Harborview, the Geriatric Clinic, has declared ourselves an age-friendly health system. So again, the focus is first of all on what matters most to the patient. So anytime we're making a plan for care, specifically pain management, we are going to be asking our patients what matters most to you. What is it that you want to do that you cannot do because you are in pain? And then looking at the modalities on medication, opioids. Today, we're going to talk more specifically about how can we help what matters most to you with these opioids. Keeping in mind that they also can affect mental status, can also affect mobility in a positive way if they are thoughtfully and kind of judiciously prescribed. If we are not as careful, we can actually obviously be contributing to greater problems for those patients in those 2 different realms. One thing I really love, and I've worked in geriatrics now probably for about 15 years. Prior to that, I did pain management for the orthopedic clinic in Harborview as well. But the thing that I like especially about working in geriatrics is that it really is a multidisciplinary team that works together on different aspects of the patient's care to give them the best optimal care. And when we're considering a multidisciplinary team, which includes obviously a social worker, physician, nurse, pharmacist, etc., I also consider the patient being part of that multidisciplinary team. So whenever, again, we're setting up goals, pain relief goals or management, our patients are always going to be central in that discussion. So speaking of pain, just generally, first of all, we want to acknowledge that it actually is a geriatric syndrome. So as we know, there's different syndromes in geriatrics. So pain itself is not a disease state, but there's a number of disease states that contribute, as well as other social and economical things that contribute to the perception of pain for a patient. So what I want to make sure that we're very clear about is that even though, you know, a patient may have hip pain, osteoarthritis, that is obviously going to contribute to leg or chronic lower back pain, there's other components that are also significant in that perception of pain for the patient. And the reason why I'm saying that is because we want to make sure that we are optimizing and addressing and acknowledging those other problems that are actually contributing to that total pain and suffering experience that the patient is having. So one red flag for that would be if you are prescribing, for instance, a patient an opioid or an NSAID or pain medication that you expect to have a certain effect, and it absolutely is not, even with titration up. It might be an indication that, for instance, if this patient suffers depression or anxiety, that those are not being optimally managed, that those haven't been optimally addressed, and that they are actually a major contributor to this whole kind of potentially a vicious circle. When we're thinking about pain management, we want to be thinking about it in what we call a multimodal approach. So obviously, opioids, pharmacotherapy are one modality for treating pain, but they are not considered, especially by the CDC, as first line. Opioids are not considered first line therapy. And what has been shown to be actually most optimal is using medication in conjunction with other things. So for instance, cognitive behavioral treatment, as well as weight loss have been shown in all different types of pain to be effective modalities for helping reduce pain in conjunction with medication. Aerobics, yoga, Tai Chi, those have also been shown to be potentially helpful as adjunctive ways to help reduce pain. And then just to reiterate this too, so talking more specifically about chronic lower back pain, just because that it happens to be pretty common, not just for the geriatric population, but a lot of patients in general. The American College of Physicians actually support first line, actually non-pharmacological interventions. And then this whole idea of pain being, we're approaching in a multimodal way. The reason why we're doing that is because chronic back pain, as I showed you kind of in that first schematic, is not necessarily solely because of one thing. And in fact, when we look at lower back pain, the reported prevalence of there being a neuropathic component to it can be upward as up to 50%. So combination of, for instance, NSAIDs or opioids with other modalities or even other pharmacological agents have been shown to be an effective way to actually treat pain. And so speaking about that multimodal analgesia, so if you are using, for instance, a combination of opioids, NSAIDs, if appropriate in our elderly, which we'll talk about, oftentimes not appropriate, with other different modalities, topical agents, for instance. Potentially you can, get a more broad, what we call a broader based coverage, kind of like we're talking about antibiotics, and using less of each modality, which subsequently should lead us to less kind of side effects and adverse drug events. So today we're going to talk mostly about chronic pain in the ambulatory care setting. But I did want to bring up this study that looked basically at over 1 million patients that had just undergone total joint arthroplasty at the knee and the hip. And what they looked at is using opioids only, so relying on opioids post-surgery as the only modality for pain relief versus opioids plus 1 extra modality or opioids plus 2 extra modalities. And what they found, or what we found actually, is that by using the more additional modalities they used to opioids, they found that they could decrease respiratory complications, decrease GI complications, length of stay was reduced, so therefore cost of hospitalization was reduced. And it also reduced, obviously, opioid use in general with its own kind of unique problems. So just again, not to go on about this multimodal idea, but very importantly that when we're thinking about opioids for pain management, we're definitely wanting to marry it with other means to help. So when we are approaching pain management in general, the World Health Organization actually came up with this, what we call a 3-step ladder to approaching when we're looking at pharmacological agents. Many of you may be very familiar with this because this has been out for quite a long time. And the bottom line, and this is especially applicable or ideal for treatment for the elderly population, is that we generally want to try to use a non-opioid or medication at first. So again, Nsaids, actually acetaminophen, along with an adjuvant. An adjuvant essentially being something that increases the efficacy of your primary kind of medication. And then as pain increases or pain needs increase, kind of in a very stepwise manner, moving up the ladder to potentially needing or using your stronger opioids. I did want to mention, I did want to give a little hurrah to acetaminophen because it actually isn't as lame as people say. So a lot of patients say, oh, I've tried, acetaminophen. It doesn't work. It's over the counter. I want you to prescribe something that actually is prescription. And a lot of practitioners potentially don't necessarily give it, a lot of credence either. But it actually is, again, in the context of opioids, it does help us, potentially reduce the amount of opioids that a patient might need to manage their pain. So it has additive analgesic with opioids. Obviously, it comes in oral, IV with and they have equal efficacy. And when they looked at actually at a study post-operatively, over a third of those patients that were in this group, it said that they had at least 50% reduction in pain just by using kind of a scheduled acetaminophen dose. One thing that I think people, when patients say, oh, I've tried it and, haven't, it hasn't been working for me, I think 2 things that we want to make sure that we're telling them is that, first of all, if you have chronic pain, you're using opioids, then you should be using acetaminophen in a scheduled way. And you should be getting a reasonable dose at a time. So, a 325 milligram regular strength acetaminophen or an extra strength acetaminophen oftentimes is not a significant enough dose. Oftentimes, using a full gram at a time at scheduled 3 times a day, for instance, can actually be, again, objectively helpful. Other adjunctive agents that we potentially can use, so again, trying to reduce the amount of opioid potentially needed, are topicals. So Nsaids, as I was alluding to, oftentimes not the most optimal option for geriatric patients. From a GI standpoint, put them at risk, potentially put them at risk for bleeding. From a cardiovascular standpoint, they carry some, in those patients that have existing cardiovascular disease, they potentially can be more problematic. And those patients that have renal insufficiency, especially if they have congestive heart failure, NSAIDs systemic NSAIDs are not necessarily optimal. But topical NSAIDs, that stay in the adipose tissue at the site. So if they are recommended from the American College of Rheumatology as first-line therapies for certain joint arthritic problems. They do stay in the muscle, in the adipose tissue around that joint, and can be actually quite effective for some patients. And you get a very significant reduction in systemic absorption. Other topicals, capsaicin and lidocaine, which also can be used actually for musculoskeletal pain, but more known for use in neuropathic pain, actually have a level B recommendation. So stating that they're probably effective in helping with pain reduction. Problems with those, as well as diclofenac. Diclofenac actually recently came out as in a generic form, so significantly cheaper. But those elderly patients on fixed income, capsaicin and lidocaine oftentimes are not covered on insurance, and so patients they do have to pay out of pocket. And you do have to apply all of these topicals kind of routinely and often, which again can be a little bit of a barrier for patients optimizing them. But just something to think about. So, as you know, there has been an ongoing opioid epidemic that has been going on for a length of time. It's been in the news, had a lot of press recently. I think the Sackler family is being sued for lots of dollars. And so, but it very much, it has been traced back to the 1990s, and it has been described actually as the largest man-made healthcare crisis of the century. So, drug manufacturers, during starting in the 1990s, heavily started to market opioids for chronic pain. And the kind of party line was that they were reassuring the public that opioids were not addictive. And actually a lot of practitioners were saying similar things, that if we're prescribing this for pain, you are not going to get addicted. Obviously, we know this is not true. And in 2016 and 2018, when they actually started looking more closely at statistics, at that time, 130 people were dying daily of opioid overdose. 11 million people were misusing their their opioid prescriptions, and 2 million people were diagnosed with opioid use disorder. Which, anytime we're talking about numbers in relationship to opioid use disorder, almost always they're going to be underrepresented, just because it often, and we'll talk about this a little bit later on, they're just often not diagnosed or misdiagnosed. So in 2017, the Department of Health and Human Services declared a national emergency, and two things happened. And this is just a schematic of kind of what was going on. So the National Vital Statistics System from the CDC, if we're put out this chart, looking from 1999 to 2010, you can see how exponentially the number of opioids being sold rose, with equally large number and kind of a concurrent number of deaths due to overdose and admissions to opioid abuse treatment centers. So two things happened. DEA began to start restricting opioid prescribing and availability. 2014, Vicodin became reclassified from a controlled 3-substance, to a 2, which was intended to help patients or slow down the kind of prescribing of this particular medication. So anything under a C2 can be called in. You can put refills on it, up to 6 months worth of refills. As you know, controlled 2 substances have to be prescribed each time, and they actually have to be written or they electronically sent. Tramadol also in 2014 was placed as a Schedule 4 medication. So then it now was showing up on our prescription monitoring program that we can see electronically, which is helpful for practitioners that prescribe these medicines to kind of get a good sense of, what controlled substances their patients are, taking, when, how much, and how often, and by who, by lots of different physicians or just themselves. And then in 2018, there was a proposal to potentially put fentanyl on a Schedule 1 status, which basically means that it has very high addictive properties with very minimal or no kind of FDA approved indication. That obviously did not go through. But also there was a proposal to actually limit the production. So the production actually of opioids, of our controlled 2 substance opioids. So oxycodone, hydrocodone, oxymorphine, et cetera. So that there just wasn't the supply for patients. The CDC concurrently also put out some actual prescribing guidelines for physicians. So they introduced a national chronic pain guideline, 2016, that set up national standards for opioid prescribing. And they explicitly stated, and we are explicitly stating today as well, that opioids are not considered first-line therapy for chronic pain. And then they also, CDC also put out guidelines on limiting the amount that you should be prescribing at a time. And the bottom line was, at least for the first phase, is just trying to avoid patients getting their hands on opioids for recreational use. So how are we doing? How have we actually decreased our opioid prescription writing? A recent study, well, actually not so recent now, but in 2018, we looked at that. And when we looked at patients that were transitioning from inpatient to outpatient settings, we found actually that there still was almost 50% of those patients who hadn't needed or taken an opioid within the last 24 hours of their stay, still being prescribed opioids on discharge. And as you know, probably know, transitions of care. So when we're transitioning from inpatient to a skilled nursing facility for elderly, or a skilled nursing facility to an outpatient setting, back to an outpatient community dwelling setting, those are the times when our geriatric patients are the most vulnerable for a number of different things, medication related. So this is just a reminder that we are not doing optimally yet. And this has to do with a number of things that are kind of on the systems level. So in defense of providers, practitioners, there are a number of barriers to them providing the best kind of mitigation of risk. We have productivity demands, so we often don't have time. Limited access to resources, so the PMP, for instance, used to be, and I'll keep saying PMP, but what I mean is the prescription monitoring program, looking that pharmacies download to in order that we can all access if you sign up to see, what controlled substances the patients are taking. That used to be a very clunky, cumbersome database to get into, and there's a lot of, kind of different things that you had to kind of do, and you kept having to switch your password, et cetera. So that was kind of difficult to get to. So there was limited access. So providers, often or had, at least in the past, limited access to resources. And practitioners, even now, there are inconsistencies among providers in their thoughts about prescribing opioids, because it can be a very polarizing topic, of course. The other barrier is that opioid use disorder, especially in the elderly, is often underreported and undertreated. So we'll talk a little bit about, kind of recognition of that as well. So I acknowledge that, I understand that there are probably, there are people here attending today that aren't necessarily practicing or working in Washington. And I'm going to be going over actually the newest opioid prescribing requirement kind of regulations that were last put out, which was in 2019. And these are specific to Washington. But when I was looking at those state prescribing requirements for other states, they actually all are pretty well aligned. And the reason for going over this is because it's all about mitigating risk. So if we're going to be prescribing opioids, then we want to do that, again, in the most standardized way we can, and the most, available way, so that everyone can kind of see and are clear on what's kind of going on with our patients. So as an overarching kind of look at these opioid rules specific to AmCare, ambulatory care, basically they apply, first of all, to all pain. So that, although there are some exceptions, so they do exempt patients that are, end-of-life care, cancer, or patients that are inpatient or have procedural pain needs. There is, as I've been talking about, there is a prescription monitoring program that all prescribers must register with. And basically the ruling is that, for each time you prescribe a C2 prescription or controlled prescription, you should be consulting this registry to make sure that you are fully aware of, kind of all the other medications that are controls that a patient's taking. All states actually have a PMP program. Some are called a prescription drug monitoring program, so a PDMP, all but Missouri actually. And there is reciprocity. So 2/3 of our states, you can actually access if a patient, for instance, our elderly patient gets moved up to live with their daughter. They were living in California. We in Washington can actually see up to 5 years back for most of these programs, what the patient has been taking in that state. There's the opioid rules also cover, screening. There's certain patients that we don't want to be prescribing opioids to. We want to make sure that the patient is educated about their opioids and what it means, what risks they're actually taking when they're being prescribed this, so that they're making informed decisions and informed goals. And we also want to again stress, as I started about talking about this multimodal approach, that we want to be also utilizing the stress and stress alternative to opioids for pain management. So one way of mitigating risk has been kind of set up as a ruling is that we are limiting opioid quantities depending on whether the patient is considered to have acute, subacute, or chronic pain. You can prescribe, obviously, well, not obviously, but you can prescribe more than, for instance, a 7-day supply or a 14-day supply in the case of acute pain if the patient's post-op, if you kind of document the reason for that. But generally, the bottom line is that we want to be only prescribing a short duration of pain medication, partly because we don't want excess, opioids kind of in the community. And the other mitigating risk that we've started to employ is, or not just started to employ, but has been employed, although I don't know if we use this as consistently, is talking the same language about our opioids. So we are talking now about morphine equivalent doses, or MEDs, or MMEs, which is morphine milligram equivalents. So when we're talking about how much narcotic, a controlled 2 substance a patient is taking, we often will convert it to what the morphine kind of daily dose is, to give us an idea really of how risky is that amount to the patient, because we often are not super clear on how much how potent really is hydromorphone, for example. People are often not clear about that, but morphine we are. So if we're talking always about in morphine equivalents or kind of morphine equivalent daily doses, then we're all better informed. So again, if we're calculating, so patients that are on chronic pain management, it is a good idea just to kind of establish what their total morphine dose is per day. And part of this is because we want to just be really cognizant of the higher the dose, the higher risk the higher dose of your narcotic per day that a patient's taking obviously gives the patient a higher risk of side effects and overdose and potential death. And when we're looking, they actually have looked at, kind of looking at a patient that takes on average 50 milligrams of morphine approximately a day versus 20, they found that actually you have 2 times the increased risk of overdose just by being on that higher dose. And what they also found through studies is that if a patient is on 50 or on 40, oftentimes, by reducing the dose to 40, you are actually making it safer for the patient. They're at less risk of these, kind of adverse drug events. And oftentimes the pain management is equal. So the patient actually doesn't feel compromised in a pain relieving way. So this is to the left here is the what we call a conversion vector. So in this, and I'm pointing this out not because we're going to do any math today, and you probably don't necessarily do this in your jobs either. But what is nice to review, since we're talking about opioids, is just how the potency of different ones. So for instance, when we're talking about methadone, or excuse me, when we're talking about morphine, so 1 milligram of morphine is approximately equal to 1 milligram of hydrocodone. So Vicodin and morphine are approximately equal from potency standpoint. Fentanyl is approximately twice as potent, milligram per milligram. And then methadone, and this is one of the reasons why we often don't like to prescribe unless you have an opioid use disorder, methadone, is because with the increase of methadone doses, you have an increase in potency, plus a higher risk of QT prolongation, and there's drug-drug interactions with methadone. So generally for the geriatric population, just as a caveat, it's a kind of a trickier medication to prescribe, and not necessarily most optimal for our elderly population. Also mitigating risk, patients that are on kind of the equivalent of 120 milligrams of morphine a day actually have to, and you probably all know this, have to have a pain consult. So they need to either go to a pain specialist, referred for that, or their primary care doctor needs to consult with a pain specialist about this particular patient. And we also need to, there are some rules around when we need to prescribe naloxone to reverse as a reversal agent to help keep patients safe in case of accidental overdose. And that equivalent for physicians is 90 milligrams. So physicians who are prescribing 90 milligrams or more per day for our patients need to provide a naloxone script. The patient doesn't need to obviously fill it, but it has to be prescribed. And if you're a nurse practitioner, then the mandation is that if you're prescribing 50 milligrams of morphine a day to a patient, you need to be providing a naloxone prescription as well. And I just put, this is the Agency for Medical Directors. This is, there's lots of different, Global RPH also has a really good calculator if you go to this website. So again, one of those ways of overcoming one of physicians or practitioners' barriers to resources, and saving time. This calculator actually is a very easy way to kind of get your MMEs without actually doing any math. Another way of mitigating risk, obviously, is education. So if we are standardly educating patients using these patient notification handouts, and then also mandating, which we do, mandate that physicians and nurse practitioners get a certain amount of continuing medical education specific to pain management. The hope is that we are, all again, being very clear about facts about opioids, their risks, etc. So for each kind of pain stage a patient is in, so if a patient is being prescribed opioids for acute pain or for subacute pain or for chronic pain, there is a mandation that they get one of these pamphlets for the first time they are prescribed the opioid while in that particular phase. And what it covers, if any of you have not looked at it, is it just talks about the risks that are associated with opioid use, how to properly store the medication so you're not putting other people in your family at risk potentially from them taking it, and then how to dispose and encouragement to dispose of it once you no longer need the medicine so that it's just not around to be potentially misused. The other mitigating risk for to making sure that we're not contributing to a serious problem for a patient by prescribing opioids is that we want to make sure that we are, first of all, not prescribing opioids to patients that have moderate to severe sleep apnea. We want to make sure that prior to prescribing opioids for chronic use, that we are optimizing their treatments for handling if they have depression or anxiety. Because opioids for some patients, if they're not, and there are medications and there's modalities that, obviously are specific and have FDA approval for treating these depression and anxiety. And opioids, although they may transiently improve a person's mood, that won't be sustained. And you potentially can inadvertently give a patient or lead a patient to opioid use disorder if they start relying on opioids to kind of help them with their depression and anxiety. The other thing about that we need to think about when we're prescribing opioids is that other concurrent CNS medicines. So what I am constantly doing in my clinic is if we want to be using an opioid, we think that it would be a very helpful modality for this particular patient. We want to make sure that we are looking at in categorizing how many CNS medicines they already are on, and if possible, making it safer for the patient to be using the opioid by reducing, if possible, the other CNS medicines. So making sure that patients aren't using over-the-counter, H1 diphenhydramine, kind of allergy medicines that have any cholinergic side effects that are CNS. If they're on gabapentin, minimalizing the use of gabapentin, etc., just to keep our patients safe from a, kind of a falls and a fracture standpoint. And then we also want to be making sure that we're cognizant or weighing in on a patient's renal status as well as hepatic status, because there are certain opioids that doses need to be adjusted or potentially avoided depending on, how compromised their renal status is. And we'll talk about that. As far as when we start to prescribe opioids, it's really important that we are weighing in with regularity. And how often we weigh in with regularity does depend, or is recommended to be dependent on how risky the opioid dose is. So for instance, patients that are on 90 milligrams of morphine daily are considered high risk. And so therefore we should be, checking in with the Washington state guidelines on a quarterly basis. If a patient's between just under 90 and 50, they're considered moderate risk. 50 milligrams of morphine, by the way, are considered, kind of moderate risk. And so, semi-annually, we should be kind of doing this kind of very formal, not necessarily formal, but a pointed review. And if they're low risk, and most of the patients that are in our geriatric population are categorized as low risk from the amount of kind of morphine equivalents that they're using a day. So we have a pain registry here, and most of the patients on it, in fact, almost all of them, are on maybe 30 milligrams of morphine per day. So they would qualify as kind of just being reviewed annually. But of course, geriatric patients have other comorbidities that also put them at a higher risk for other reasons. And so we obviously review their pain management more regularly. Concurrent with that, another way to kind of just make sure that we're keeping patients safe when we're prescribing opioids is doing U-toxes. And the frequency, is kind of based on risk. And the U-tox, obviously we want to make sure that we're doing unannounced if possible, so that we're getting a really good picture of kind of what's going on when the patient is not, if they're being prescribed or other medications that they haven't mentioned, although we'd see that now on the PNP. But if they're taking things independently, that potentially could put them at risk for maintaining or staying on the opioid. And then just we're going to be, the important thing about pain management is that it's not a one and done. So you set kind of your speed control and just never address it again. It's important to keep revisiting with the idea that, for instance, patients that are on 50 milligrams of morphine equivalents a day, there is without any evidence of benefit, really should be potentially tapered off. If they're on concurrent benzodiazepines that we can't taper off the if we don't want to taper off or we don't feel we can taper off the benzodiazepines, then we probably shouldn't be prescribing the opioid because we're putting them at a much higher risk of respiratory depression, et cetera. And then obviously those patients that, just have very clear signs of potential misuse shouldn't be maintained on opioids in general. So speaking of U-tox, I wanted to just, we'll use a case just to discuss this. So an 86-year-old community dwelling person returns to clinic today. She's on 30 milligrams of oxycodone daily, which is approximately equal to, if we were to convert, to about 45 milligrams of morphine a day for her lumbar stenosis. And her U-tox comes back negative. So why is that? And what would our next steps be? So this is not, this is just for our own contemplation. So one scenario actually is the caregiver, family members not giving the patient the oxycodone at all. So we want to evaluate the living situation, and we might need to actually switch this patient to a non-opioid agent if that caregiver, if we can't replace a caregiver or whatever. Next scenario is that she's actually selling it to supply her income. Third scenario is that she actually ran out of it about 4 days ago. And so and she's doing fine. So maybe we should reevaluate her narcotic need and possibly deprescribe. So I was just going to take 1 second for us to just think about what might be the scenario there. So really, any of these scenarios could occur. The most important thing actually is that they all could be possible. And I think that we need to it's just a reminder that when we are prescribing opioids, that we are not necessarily being thinking in a really negative way and distrustful way, but we should be aware that, there are, by prescribing opioids potentially, we can be giving patients kind of unwanted attention or potentially not being managed well. I'm bringing this up just to remind us that one thing, if you're doing a U-tox, you want to really make sure that you're asking the patient, hey, have you been taking this medication? have you taken your narcotic in the last, or opioid in the last, 3 days? Because if they haven't, then this is not the right time to do a detox, because this is a length of time that drugs stay in the body and can be detected in the urine. It's not going to show up. So you're going to have a negative detox, and you're not going to be any further ahead as far as, kind of deciding on things, management, that is. Okay, I'm going to ignore this just for sake of time, and jump to just talking about opioid use generally in the elderly. So I've talked a lot of kind of, things to mitigate risk. Try to avoid your narcotic or prescribing opioids and that sort of thing. But I did want to emphasize and give actually a plug for actually prescribing opioids in the elderly. Because oftentimes, our elderly population is unique in the sense that often, well, like younger patients as well, oftentimes they though are on fixed incomes. And so opioids actually are a more affordable alternative than potentially those long-acting, expensive narcotics. In younger adults, where we might be doing an invasive or procedure or surgery, some of our elderly patients, the risk from surgery, from infection, not optimal or expected optimal recovery, those sort of things potentially put a patient more at risk from undergoing surgery than actually using opioids, kind of low dose opioids on a consistent basis. Certain medications that we also use in younger adults, Nsaids or certain CNS medicines, are not optimal because they can put patient at risk for GI, renal, hepatic, and cardiovascular events. And the great thing about opioids is actually they do have a lower risk of in-organ damage. They do help decrease disability and increase mobility, and so therefore they also can help increase quality of life. So there is a place in therapy, again, for using opioids. Conversely, we also, have to be cognizant when that we're also potentially giving patients problems. And what I wanted to highlight most specifically is that there is a lot of comorbidities that our patients already at risk for. So constipation, urinary retention, and cognitive impairment often already exist in our elderly population. And opioids, especially if they're prescribed at too high a dose, potentially can be problematic for our elderly patients. So as far as opioid selection, dosage, and how we think about how we want to prescribe for our elderly patients, an important thing to note is, and if it's for chronic pain, we really should be probably administering regularly so that they get consistent relief and avoid these long-acting formulations, at least when we're starting. You want to make sure that you're documenting the baseline status for the patient and then assessing tolerability about 3 days after. So assessing for efficacy, obviously we need to give the medication some time, but if a patient is not going to be tolerant, too much somnolence, dizziness, etc., those things are going to show up relatively soon. And so we want to make sure that we're weighing in with the patient about that. And then when we are wanting, as I was mentioning about regular kind of check-ins, we want to be kind of assessing and documenting in a consistent way. So the 3-item PEG, which stands for pain intensity, pain interference with enjoyment, and pain and general activity, are kind of 3 realms looking at intensity, pain intensity, and also quality of life and functionality. Is one validated kind of assessment scale that you can consistently use, just so you kind of have a sense of, how the patient is doing on their particular regimen. There are a number of age-related changes that affect the elderly population. So there's the pharmacokinetic changes, so how the medication actually moves through the body. And so we need to be cognizant of the fact that in our elderly population, there can be decreased renal function and liver mass and potentially hepatic flow, which can cause certain narcotics to accumulate. That might affect what choice of narcotic we'll use. And there can be changes in distribution. So some patients as we get older are more cachexic, less fat deposits versus some others that have more so. And fentanyl, as an example, which is lipophilic, potentially isn't an ideal medication to be used in a patient because there won't be good absorption if they don't have an adequate amount of fat. Pharmacodynamic changes, so that's talking about, that occur in the elderly. And what we mean by that is just the mechanism of action. How does this medicine work in the body? With the elderly, they do have an increased sensitivity to mu receptors at the mu receptor sites. So less medicine actually goes further for these patients. And we need to be cognizant, again, as I mentioned, that geriatric population has a thinner GI mucosa, so they're at higher risk for bleeds. Okay, so to talk about choice of opioids in our elderly population, I was going to use this particular case. So Mr. B, 73-year-old, with refractory multiple myeloma and chronic tumor-related pain, was in the hospital for a long stay following a mechanical fall. Serum creatinine was elevated in-house at 1.8, but almost back to normal at 1.2 when he was discharged. And he gets discharged to a SNF and on morphine extended release 30 milligrams Q12, so averaging 60 milligrams a day, plus some breakthrough morphine. The nurse notices that the patient is quite somnolent and starts nodding off during the day. What changes would you make to this patient's particular pain regimen? So, nothing. This might actually be just the patient's baseline. So we don't need to do anything, and he's not complaining of pain. Secondly, we can reduce the dose or decrease the frequency of morphine. So a lot of times the medications that accumulate, one way to kind of, mitigate that is by, lengthening the frequency or elongating the frequency or reducing the dose. So that's one option. Or we should actually just consider changing it to an agent that is less likely to accumulate in renal dysfunction. So one thing that is important to note about narcotics, they're not all the same as far as whether they should be used in renal dysfunction or not. So the good thing, although we don't often necessarily want to use fentanyl and methadone for specific reasons, they are actually not renally clear. So they're actually not a bad option if you have a patient that is very compromised renally. You won't necessarily want to use them for other reasons, but they're good that way. Morphine, however, does have active metabolites that actually accumulate, and they're more active actually than the parent drug. So you do with patients that are renally compromised, that you do have an increased analgesic effect with less, but you also put them at risk for delirium. And so therefore those patients, our geriatric patients that actually are, kind of renally compromised, morphine is not necessarily a drug of choice. Hydromorphone and oxycodone. Hydromorphone does also have a slight risk for delirium because the metabolites are active in that regard, but not so much so as morphine. And so the recommendation, if you're using hydromorphone, is that you could reduce the dose, be just more judicious about it and still use it. And oxycodone we do use in kind of renal insufficiency. Again, just reducing dose. What I wanted to stress with this chart is that when we're switching opioids, we want to make sure that, so for instance, if you wanted to go from morphine to a patch, a long-acting fentanyl patch, because the patient is on a very stable dose and they have, and it's just an easier, more consistent way of delivering the needed narcotic. And so you want to maintain the dose. One thing that is important is that when you're switching narcotics, because we have, each narcotic has different kind of tolerance, and patients have different tolerances to different opioids, and we don't necessarily know how tolerant a patient is going to be until they are actually switched. We want to make sure that we're erring on the safe side. So the recommendation is that if you're switching, that you look at the daily dose of that particular medicine, and then you're reducing it by approximately 50%. The recommendation often for elderly patients is 75%, but I've never done that, and I've never really seen anyone do that. But it is part of the guideline there, so that's why I'm saying it. But you want to at least reduce at least by 25%, and then titrate up just to make sure that you're not, kind of overdosing the patient. I put the slide in here because I wanted to just emphasize that obviously narcotics have some side effects: nausea and vomiting, constipation, sedation, confusion, respiratory depression, obviously very worrisome. We do tend to develop tolerance to these, to most side effects of opioids if you're titrating up slowly, except for one. And I just wanted to make sure that we were all, reminded of this. So do we know which one that is? So it's constipation. So, and because of that, we want to make sure that when we're prescribing opioids, that we're also making sure that the patient is taking, a stool, or excuse me, a stimulant to kind of keep the bowels moving. And also, or additionally, if needed, an osmotic agent that kind of pulls water in so that we don't have hardened stools, because we all often, our elderly patients have a constipation issue anyway. And then the caveat to that is that, you're checking in because there has been patients where they have terrible diarrhea. They haven't thought to stop these two agents because they were prescribed it. And so of course they want to be adherent to your prescribing recommendations. So checking into, because potentially they won't necessarily need it. Okay, I wanted to talk also about just three particular narcotics in general, not in general, but specifically because they each have some kind of caveats that I think are worthy of discussion. So Tramadol, firstly, is not a true opioid. Okay, it actually is. It's part of its component is an antidepressant, and it is only really used for mild to moderate pain. So we want to make sure, and what I have seen sometimes is patients being prescribed this too long. In other words, because it's easier to prescribe, you can call it, and you can call it over the phone, and you can also put refills on the prescription. Sometimes we are pushing the dose instead of potentially switching to maybe a higher potency medication like oxycodone that would be more appropriate, because with higher doses you do actually have higher incidences of dizziness and drowsiness, etc. Fentanyl, what I wanted to stress about fentanyl is that it is not indicated for patients with that have acute or post-surgical or intermittent pain. So only for opioid tolerant patients. I have seen there was just a short period of time a while back where there was people, the residents were wanting to prescribe patients for fentanyl when they were inpatient and not necessarily going to be using the medication on a long-term basis, but they were having a very hard time controlling pain, and the short-acting narcotic was being like very much jacked up. So just a reminder on this, for opioid tolerant patients only. If you have a patient really that's quite cachexic, you may not necessarily want to use it because you may have inadequate absorption. It does need fat. And there are some dosing because it's a patch, the onset of action is delayed. And when you remove the patch, there is still a continued onset of action. So we want to make sure that we're aware of that. If you ever, when we're potentially switching fentanyl to another narcotic. Heat, so patients with lower back pain, we often recommend heat, can increase the absorption, so increase the intensity or potency of your fentanyl. So you want to make sure you already know that, and you don't want to cut the patch, nor the dosing for that. Buprenorphine, this has been around since 1969, but it is now gaining some traction in the elderly population because it has what we call a agonist-antagonist effect. And because of that, it is considered less risky from a respiratory depression standpoint. It does not have significant QT prolongation like methadone does. And its metabolite, one of its major metabolites, buprenorphine, doesn't cross the blood-brain barrier. And it is completely safe in renal failure and dialysis. So part of the reason why it hasn't been as popular is because it is kind of tricky to dose. So there isn't you notice there wasn't a buprenorphine to morphine equivalent because it is also an antagonist agonist. It comes in a lot of different options. And for those patients that have some cognitive impairment, it may not necessarily be the most optimal medication because you really cannot swallow it. If you swallow it, then it actually becomes completely inactive. So what you must do if you're using a film or sublingual tablet or a buccal tablet, you actually need to kind of park it in the cheek and let it slowly dissolve into that, the fat tissue. And that's how it enters the systemic, how patients start to will absorb it. Its use in the elderly, though, is actually quite optimal. So there's less cognitive dysfunction than other opioids. And they've actually studied it and found that it does not only help with pain, but also with sleep and quality of life. And you don't need to adjust, like I said, for renal problems. There's no pharmacokinetic changes. And it is the only opioid that is not associated with fracture risk, unlike the other opioids. So that's another nice thing. Okay, so I am looking at the time. It is 5:15. The slides that I sent you have, there's so much to talk about when we're discussing opioids. And I think good information. So what I'm just gonna skip over a number of different things. What I wanna stress in the last 5 minutes here is that when we wanna make sure that we're paying attention to the potential of giving our patients an opioid use disorder or kind of a problem in that regard. And what has been found is that increased substance or drug exposure. So the more exposed a patient is to, for instance, an opioid, that alone puts them at higher risk for substance use disorder. There is the individual factors, societal factors, and then comorbidities, et cetera, that contribute to whether or not a patient will actually develop substance use or an opioid use disorder. But we want to make sure that we're, kind of watchful for this. This slide was just is showing you just that there is a high prevalence of use of painkillers, we call them painkillers, alcohol consumption, etc., CNS medications that are used by our elderly population. And when we're looking at for red flags that potentially indicate that there might be a problem, there's certain patterns that might be suggestive of substance use disorder. So if a patient is appearing, obviously intoxicated, sedated, or confused, that would be, we probably would automatically be checking into that. But if patients start reporting that they're taking one large bolus daily instead of as prescribed, like twice a day or 3 times a day, or saying that they're needing higher doses, that might be a red flag suggestive of substance use disorder, of a substance use disorder. If they're constantly asking for early refills, and if they're getting multiple scripts from different providers, those are also things to think about in the back of your mind about, and maybe checking in a little more carefully about that. And there are a kind of a suggested standardized way of looking at that. So we want to make sure that we're screening. This is a very intuitive algorithm, but we're screening that you are conversing with your patient and providing feedback and advice about if you're concerned, obviously you would do this, and then actually making sure that you're referring to a treatment program. Okay, so to summarize, I want to reemphasize that opioids are not first-line therapy for pain. We want to make sure when we're prescribing opioids that we have an explicit and a multimodal approach to pain. And again, talking about an age-friendly approach to pain management, we want to make sure that the patient and provider are, coming together with the same realistic expectations about the modalities that are being offered and what kind of relief a patient should be expected to have. And we're reviewing the benefits and harms of opioids on a routine basis. We want to make sure, again, we're monitoring and always trying to deprescribe if appropriate. And the last thing I wanted to just leave us with is something positive. And that is that more than 90% of patients actually are willing to stop medications if their doctor or provider says that it is possible. So just you telling a patient that you can do it and helping them along with a plan potentially to utilize not only the narcotic for pain relief, but also those other modalities that have been recommended. You potentially can keep your patient safe if you are prescribing opioids. All right, and that is the end of my formal discussion here. Time went by very fast. And looks like we're at 5:40 mark here, or 5:20 mark here.
This was great, Dr. Crawford. I do have a couple of questions already if you're ready for that.
Yes, please.
Okay, at what dosing level are PAs required to prescribe naloxone?
So, you know what, that is interesting. I think PAs are considered, at least in Washington State, kind of an ARNP, I wouldn't say level, because, levels, so it's 50.
Okay.
Mm-hmm.
And then another question from earlier on, isn't diclofenac sodium gel available over the counter now? And what are the pros and cons of the various strengths of this topical?
Yeah, so as I mentioned, it is over the counter, like you said. So it is a lot cheaper because it was actually quite an expensive medication. There are different strengths. Really, it actually comes in different forms. So there's actually, there's actually a diclofenac patch. There's a gel, cream, etc. The 1% is actually the strength that has the indication for pain. The 3% is actually for keratosis, actinoid keratosis. So it actually has a slightly different FDA indication. So it's not the 3%. There's a 3%, but that isn't really, doesn't have FDA approval for pain relief specifically.
Other questions, folks? This was really nice, thorough presentation, Dr. Crawford, and I appreciated you trying as much as possible to address the different providers, as well as, there's differences across the states, and it gets kind of confusing.
Yeah. I think, just the bottom line is that, there really, and it does make sense that there is a standardized approach, just as there is for, blood pressure. We have, we have guidelines for that, and what modalities we're going to use. And we're all kind of clear on that. And I think with pain management, it's starting to come around where, there's a kind of a standardized approach that we're all using. And so, and that benefits the patient as well, just so that they're getting a consistent message. Because I think with pain management in general, it can become very personal to a patient. And especially our elderly population, that has been prescribed it for life. I always have this. I'm always prescribed this. I've never had a problem. And because they often they lack a little bit of the insight of, as you get older, you actually, the harms of the narcotic potentially can outweigh the benefits that you think you're perceiving. So, yeah, it can be, pain management actually in the elderly population for a lot of different reasons can be quite challenging.
Well, do we have any other questions, folks? This is your last chance, although I'm sure Dr. Crawford would be willing to respond to questions if you send, I can't remember if you put your email there, but I can certainly convey them to you.
Sure. You can also, so I can verbally give you this.
Okay.
My email address is ccrawf, as in Frank, at uw.edu. I'd be more than happy to answer any questions you might have, or further explain, elaborate on things that I might have kind of glossed over due to time here. So I'm the pharmacist for actually not just geriatrics, but for a couple of other kind of service lines. So I will tell you that I definitely will respond, but it won't be necessarily in the most timely manner.
Okay, everyone, I'm going to go ahead and send the information for the links that you've been waiting all term for again. And I really want to thank you, Dr. Crawford, because this is such an important topic. We struggle with it a lot, particularly in our older adults, because the issues are slightly different. We're trying to do some deprescribing, but also address chronic pain, and so it's kind of a tightrope to navigate. So I really appreciate this information.
Yeah, no, my pleasure.
Everyone have a wonderful, wonderful summer. I hope that it's very safe but reopening for you. And we'll see you next January. Thanks a lot.
Bye.